Welcome to the Academy of General Dentistry podcast series featuring Dr. George Schmidt. Each episode features experts in the field of dentistry who share insights and inspiration to help you succeed. Let's get started.
Welcome back, everyone. We've got another fantastic show for you today as we welcome the one and only Dr. David Hornbrook to the program. We're really excited to have him on. He's, of course, one of the featured speakers at AGD 2026, June 24th through 27th in Las Vegas, Nevada at Caesars Palace. So make sure you register for that, especially for the early bird, which I think ends on April 30th, because included in that, you're going to get to see Dr. Hornbrook at no additional cost. So Dr. Hornbrook, great to have you on the program. Welcome.
Well, thank you. I appreciate it. I'm honored.
Yeah. So before we begin, make sure you like and subscribe to our channel. Hit the like button, ring that bell. That way you'll be among the first to be notified of all things AGD. And again, of course, I said my guest today was Dr. David Hornbrook. And although he needs no introduction, I'm going to give a little bit of a background here for him. So Dr. David Hornbrook graduated from the University of California, Los Angeles School of Dentistry and has been in private practice in San Diego, California for the past 36 years. He's a pioneer in live patient aesthetic dental treatment programs and was the founder and director of LVI, PAC Live, the Hornbrook Group, and Clinical Mastery. He has lectured internationally on all facets of dentistry, including porcelain veneers, implants, dental materials, occlusion, and direct composites. He's the past editor of the American Academy of Cosmetic Dentistry's journal, the Journal of Cosmetic Dentistry, and is an accredited fellow of the AACD. He is also a fellow and diplomat of the American Society of Dental Aesthetics and a fellow of the American Academy of Comprehensive Aesthetics. And he was honored with a Lifetime Achievement Award by the Crown Council on the Academy of Comprehensive Aesthetics. Hornbrook has developed numerous materials and techniques that are used daily by restorative dentists and has consulted numerous manufacturers on dental materials. He's the clinical director of education and technology at Utah Valley Dental Lab in Provo, Utah. And that is a one storied career that you have there.
I've been busy, very busy.
Yeah, you've been busy, been around the block a few times. And, that's a great sort of segue to open here, what I wanted to talk to you about. A lot of great things we can discuss, and we could probably stay here all day and talk. But, over the course of our careers, you're nearly 40 years, me nearly 30 years, we've seen such an evolution in dental materials, but ceramics in particular. If we talk about things like Empress and Empress 2 and feldspathic porcelain and lithium disilicate and now zirconia, talk to us a little bit about how that evolution has sort of impacted your practice and what you've done over the years.
Well, and you're absolutely right. I think the evolution is crazy. When I graduated from school, when you graduated from school, you took an impression and you either did a PFM or you did gold. You wanted to never break, or you wanted to kind of look like a tooth, right? And I always say the more tools we have in our tool belt, the more options, the cooler it is. So now we look at our tool belt, we've got all the options, and it's crazy. We need to keep up. I think it's important now, especially with these young dentists, to really understand the evolution of the materials and what's available and the contraindications and indications. I'm a guest faculty at numerous universities. It surprises me that a lot of the dental schools now don't even require the young dentists, I say the dental students, to do any lab. And so not too long ago, I was lecturing on a Friday night in Roseman in Utah, and I was talking about how they make EMAX, right? And Empress and leasing press and fabrication process. And I said, I don't really need to go into it in detail. We're going to short of time because you know how they cast gold, right? It's the same. And I started to move on, and it was like, 200 students with their deer in headlights. And one guy raised his hand and says, we don't know how to cast gold. I said, well, you don't know how to cast gold? Because no, we never talked about how they make these things. So I think it's important for these young dentists to really understand how these things are made and when you should use what. We get inundated with flyers and ads and these labs that are providing these restorations for $49 or $59. And this is something that is the best for all indications. And, you mentioned I'm the director of technology and continuing education at Utah Valley Dental Lab, which is a high-end lab in Utah. And they're very digital savvy. And it's just crazy how these things are changing. But I think it's important, again, for us as dentists, we're scientists, that to really understand the advantages of these materials versus just taking some ad and say, oh, that looks good, it's a cheap price, and this person said it's the greatest thing since sliced bread, let's use it. So it's been fun and it's been challenging, It's been challenging in the way that there are so many materials available. They're changing constantly that we need to keep up. And it's been difficult, I think, for a lot of clinicians.
No doubt about it. So, I teach at Nova down in South Florida,
Yeah.
and we're almost completely digital. I mean, there are some requirements where they have to do an analog crown, but there's literally no lab work other than pouring up a model. Everything's scanned, everything's digital, everything's milled, printed, right on from dentures right on down. And I remember back, of course, and you do as well, when we were in school, I mean, we had to cast our own crowns, cast our own posts and cores and gold crowns and all that kind of things. For better or for worse, I think that's kind of been lost in the profession. But some of the materials that we have and have evolved over the years, incredible. Let me just back up a little bit. So, years ago, I used to do a lot of Empress and Empress anterior cases. Are you still using those materials, or kind of have you moved away from that? Talk to us about what you're using now.
I wish I could use Empress. Empress came out in 1994, so we have a huge clinical experience with it, but it was discontinued about 6 years ago, except in a block form. So since we're doing everything wax and press, at least the ceramics that I use, and so we really can't use Empress anymore. The CERAC docs, or if we requested an upbuild Empress, it's still available. It's called a multi-block. It's actually really good.
Yeah.
I think it was unfortunate they discontinued Empress because still the cases that come into my office on a daily rate, the ones that jump out at me and say, "Look at me, I'm a pretty one." It's always Empress.
Yeah.
So it's unfortunate. Again, a lot of younger dentists don't even know what Empress is or that it exists. So it's been replaced. I mean, there's a lot of good materials that are stronger. We used to always, and we went through this evolution, we wanted to look good and wanted to be strong. Right? And if you had something that was strong, it wasn't very aesthetic. And even when zirconia came out monolithic in 2009, still it was something that was very ugly, but you could cement it with anything and it's not going to break. So clinicians had to make the choice to, I want to deliver something that doesn't look that great, but I don't have to worry about it breaking and I don't have to want it necessarily place. And the cool thing about, again, this evolution, whether it be milled, whether it be pressed, we're combining and we're marrying the two, aesthetics and strength. And obviously, when EMAX came out, it's been 20 years. It's hard to believe that with the silicon EMAX has been on the market 20 years.
Yeah.
I still have clinicians say, "Well, I don't use it because I'm waiting for it to get proven." It's like, dude, they have like 200 million documented restorations worldwide.
Yeah.
And we have improved, but EMAX, I personally do not think it was nearly as aesthetic as compromise. But the patent expired, and now there's a lot of, I'm not going to say me-too products, but a lot of different lithium disilicates on the market that are very promising. We're playing with these different materials in the lab. One of them is Lisi Press. Lisi is a GC product. That's my go-to. I just think it's prettier than EMAX personally, with what my ceramics is doing. And it's got the physical properties that EMAX has. It's got the aesthetics, I think, close to Empress. And then there's Amber Press and Amber Mill. And it's a awesome product. It's very, very promising. But we're seeing, fortunately, we've seen the manufacturers come out with products that now they can experiment since patents are expired. They can experiment with crystal size, shading, opacity. So we're seeing a lot out there. So my recommendation for clinicians, if you're getting cases that you just don't care for the aesthetics, whether it's too gray, value, is talk to the ceramist, see what they're using, because most ceramics and laboratories are trying to deliver the best product that goes out the door. They want it to look beautiful in the mouth. And so they're experimenting a lot with materials. And zirconia, fastest growing restoration in history of modern dentistry. Over 80% of restorations prescribed by dentists in North America are zirconia, 80%. That's a product Jim Bible introduced the products in 2009. That's only 17 years old, and yet it's 80% of the restorations, and maybe even higher. Because that was a study done by LMT 2020. So I mean, it's already been 6 years. But we're getting zirconia that looks like lithium disilicate. I mean, it's aesthetic, it's translucent, and yet it's twice as strong as so it's interesting. the print, what we talked about before we started this is, where printing comes in.
Yeah.
And I don't know what you're doing down in Nova. I personally do not think we're really that close to printed definitive restoration. I think it's a great long-term temporary, but with social media, these doctors are either trying to sell it for us, or they're trying to say, "Oh, I did this and it only cost me $7 for 10 years. I did it, 2 hours." I think, wait a minute, it's plastic, right? And are we there yet? I don't know, but what's interesting is most of the materials for printing were being manufactured by the companies that made printers, and they're not materials companies, right? Now the big boys are getting involved. I had a dinner with the people from Ivoclar last night. Now they've got in the printing world. Now they're developing products because they realize it's a developing market. They are developing product to meet the needs of aesthetics and strength. So in the next couple of years are going to be very, very interesting. When the printers are going around. They're printing bulk. We could print stuff in our office, or even if you didn't want to design it, you could have a printer much more affordable than mill. You could go ahead and take your scan, send it to your laboratory. Laboratory can design it, send it back to your printer, and print it. You could have that restoration in a couple hours. It looked like a beautiful lab work ceramics. Yet have the physical properties and aesthetics that we see in ceramics. That's when it's going to be exciting.
No doubt, no doubt about it. And you and I were both in Chicago midwinter, and I happened to go up to Lab Day, which was up the road from there. And the things I saw there were just absolutely incredible relative to printing and all that. I mean, as with anything else, I think that the future is bright there. And like you said, I think with the bigger companies coming in there, once that competition hits and there's a drive for product, I think things will be coming more and more refined and better.
I actually like the Lab Day better than the It's so fascinating. Now we have these Korean companies. If you go to the IADR in Cologne, it's booth after booth that are these Korean companies that are developing not only implants is one. They're developing a lot of clones that are just really amazing. But the printing and the mills are, and the cameras, with our scanners, intro scanners, where it used to be, do you have this one or do you have this one? And now we're inundated with dozens and dozens of control scanners that are affordable and very, very accurate.
Yeah.
But it's kind of interesting you mentioned. So I spent a lot of time at Utah, and my relationship with the lab is I'm like the third leg of a stool. You have the ceramist on one side, you got the dentist, they interact. If they ever have a situation where I think I say the stool is wobbling a little bit, that could be taking bites or choice of materials, or prep design, shape. I mean, it could be anything, smile design. Then I put my leg on the stool, and I am now this third person in this relationship. And as fast as the clinical side is changing, the lab side is changing 10 to 20 times faster than the doctor side. And almost every time I go up to lab, now I don't go about once a month, I walk in the digital section, and it's like, what is that? I didn't see that last month. Oh, that's a new printer. It's like, I thought we had, we have 3 carbon printers, they're $500,000. I said, no, this is actually more accurate, smaller, cheaper. And we're using this for the dies. And I thought, wait a minute, we're running out of room for one. There's all these toys. I think it's just fascinating. But it's changing. And I think as clinicians, since we're talking about the clinicians, if you want to keep updated, talk to your ceramist, talk to your laboratory, go visit them. It's amazing to see the change.
I think that's important. I think that's important that you point that out, because especially a lot of the younger dentists, when you come out of school, because I'm in that world now, education, and some of the younger folks come out and you expect to be the dentist and the expert, but my God, you got to go to the lab. You got to see what these guys do, because they know what they're doing. I mean, they know what they're doing, right? You gotta get in there.
Well, and then, I mentor 50 young dentists every year through Crown Council. I've been doing that for 20 years. We have almost 60 this year. And the thing I tell them is, have that relationship with ceramics, because they come out of school in 4 years and they really don't have that much interaction. They're doing dental school dentistry, which I'm not going to say is a bad thing. That's a foundation. but it's certainly not the icing on the cherry on the top of the cake of things that they need to stay educated. And, so who's the dean down in Nova? Because it was Linda.
So Dean Kaltman, Steve
Okay.
Kaltman. Yeah. So although I believe at this point we're going to be looking for a new dean.
Okay.
I think Dr. Dean Kaltman is going to retire shortly or soon. So yeah, so they're in the search now, I think.
Good. Well, the students are lucky to have you, that's for sure, for you sharing your wisdom.
Absolutely. Well,
They may
thank
not
you.
know it, but they're very lucky. So
Yeah, no doubt. Thank you. So thank you. So, as the third leg of the stool, I got to back up a little bit. I want to tie this back into Empress because I did love that material. And, we're always looking for the next best, strongest thing. But do you think that's a function of people don't understand occlusion versus the fact that the material is not strong enough, right? Because if the occlusion is good, I think you're good.
I totally agree with you. I've got probably 50 full mouth rehabs, 28 units of Empress. I'm not the guy that's going to say nothing in my stuff ever break. It's going to stuff break.
Yeah.
But they don't blow up. I'm not seeing all these things break with a ceramic material that is half the strength, but with the bisilica, a fifth to sixth the strength as a phone. But the reason it's successful, because I manage the function, I manage the bleeding and stress and forces on the teeth. And I think a lot of dentists don't do that. They're thinking about your education. Dental. Where'd you go to dental school?
Rutgers. UMDNJ. It's Rutgers now.
Okay. We learned about occlusion, but it was so esoteric. We'd make splins, we'd try to get CR, and then we'd go down to the clinic and everything was in CO. So role of the articulator and trying to get this ideal joint position. And, I got out of school and my articulator became my doorstop. And it's like, why would I use that? I'm doing CO dentistry. And then the more dentistry I did, the more failures I had because I didn't understand it. And so it's so important that we're understanding function. And I think what has happened is dentists and laboratories and manufacturers have said, listen, we're seeing too many failures. We're getting calls, we're getting emails from a restoration that we made, and now it's breaking long before we have to break and fail. And so they say we just got to make a stronger material to deal with the inadequacies of the dentist understanding forces and function. In fact, I'm still doing live patient courses. I've been doing that for almost 30 years. Is we changed it from live patient aesthetics course to functional aesthetics. Because everything we teach is, if you've got a patient that has wear, you've got a patient with a chip in the front tooth, you just don't put glass or plastic on that and you're going to have success. So you got to ask the questions: why did that happen? And let's fix the cause, and then we can put whatever we want.
Yeah.
So you're absolutely right.
Yeah. So, I know you were a part of LVI, Bill Dickerson, and that's and I don't want to start a big thing here, but the neuromuscular camp versus the Dawson camp, one way or the other, or do you think there's a spot for everything in the scope of what we do?
Yeah, again, I'm not going to get political. The neuromuscular came long after I left LVI. I'll just make that statement. What we're teaching now, my philosophy would be, I don't say I'm a CR dentist. I think the CR definitions changed over the last 50 years, but I believe that the muscles should drive the condyle into the correct position. I call it muscle centric. We use a deprogrammer like Voices here and Painty and Dawson and Christensen and Bill Strupp, trying to get the muscles to pull the condyle into place. Is that the quote unquote traditional CR that Dawson talked about? I don't know. As long as we have comfort as repeatable and not seeing failure or pathology, that could be data failure. Do I think neuromuscular has a place? I think the original way neuromuscular was designed, absolutely. I think the technique was kind of bastardized a little bit efficiently. And with LPI, fingers, I think they've kind of come down from what they were doing in the past. They're doing some good stuff now. But I think we tend to argue about stupid things. It's like, what I want is I want the patient comfortable.
Yeah.
I want it to look good. And I want it to last. And those are the three things. Whether you do it neuromuscular, whether you just do everything with CO and it's successful. I mean, whatever it is that we can accomplish those three things, I think that's the right way. I have my philosophies and teach an occlusion course as well, a hands-on. And that's my philosophy, but it doesn't mean it's the only
Yeah.
philosophy.
And I think that would be a good definition of success or a successful case for sure.
I think so.
Yeah. Dr. Hornbrook, we got to take a quick break. We'll be right back. This AGD podcast series is sponsored by DHP, one of the largest family-owned full-service dental dealers in the United States. DHP provides dental and medical supplies, equipment repair and maintenance, technology, and equipment sales. AGD members receive exclusive discounts and promotional offers when you buy from DHP. We are especially grateful for DHP's continued support of AGD. Their partnership helps make this podcast and these vital conversations possible. Discover why like-minded general dentists work with DHP by visiting their website at dhpsupply.com. Hey, welcome back, everyone. We're talking to Dr. David Hornbrook here. We're having a great discussion. And you know what I want to pick up with is we talked a lot about materials. So, when are you using what where? So let's just talk about the posterior, for instance. So when are you think perhaps using maybe an Emax or something along those lines, or that kind of material, lithium disilica, whatever you want to call it, versus a zirconia nowadays?
Well, again, this is my bias, and so it's subjective. I am a fan of the HT, the high translucent zirconia. I'm using it my go-to for full coverage crowns in the posterior. So if I did full rehab, even if you came in and replacing your whole PFM or it's a single unit or it's multiple units and it's already a full coverage crown prep, I think zirconia is a great option. We can bond to it. We know it's wear compatible. We look at the clinical side, and for dentists, it's usually less expensive than any the other material. And you can cement it with anything you want. And so, those are, and it fits. So there's a huge advantage. Do I think it's the prettiest material? Not really. And I think digital dentistry too, most digital designers tend to not put as much anatomy in posterior restorations that I like. I'm a firm believer in sharp cuts, deep fossa, much of anatomy. I call it a working occlusion surface. It's designed to chew food vertical, right? So zirconia now, my practice is if there was already a full coverage crown prep, then I'm replacing it. Again, that would be part of a full mouth rehab or could be a single unit. I don't use any metal in my practice. I have to put an asterisk on that because I do hybrid abutments for implants. So I have a titanium or gold base, and I do use a gold or a titanium spur, but that's it. So the other place I'm using zirconia is multi-unit bridge. If you came in and did one of your implants and you wanted a bridge from 6 through 11, that would be a zirconia supported. So because we could use what to trigonal, and we're going to talk all about this season. That's an ugly material, so you got to cut back and you got to layer something that looks like materials, right? So that's my philosophy. Anything in the anterior, and I'm going to call premolars anterior forward is going to be the best. What I'm using in my practice against least press. But if doctors are having a good result with Max, I would say your labs and master don't change. 20 years of experience. So, if we get back to kind of what we were talking about earlier, I'm willing to give up strength a little bit in the anterior if I know that's aesthetics. I'm willing to give up aesthetics a little bit, although I don't think we're giving it up much with the new HT zirconia in the posterior. So a lot of my full mouth rehabs are the anterior 20, second bite to second bite, the next one, and then are lithium disilica, and I've got 8 molars that are zirconia bands.
So let me ask you this: when you stage your cases like that, when you're going to do a case like that you're going to do the anterior 20, so you're going to do the anterior 20 first and then come back after you maintain the occlusion or establish the occlusion, and then come back and then do the molars secondary to that?
Yes. So the way, and I'm going to cover this in detail, about the first 2.5 hours, we're going to talk about taking bites and getting correct bites.
Yeah, fantastic.
And, as kind of a side to that, that's the hottest topic. You look at the forums where these guys talk about why they have failures or how do they take the bite. And on the lab side, we're seeing more dentists doing complicated cases without any training, right? So and the questions that are coming in, it's all about how do we take bites? How do we get this stable? Okay, how do we systemize the delivery and the sequencing. So we're going to talk a lot about that.
Yeah.
Vegas. So I always restore the anterior first, and I do that for a number of reasons, because I think aesthetics drives function. Function doesn't drive aesthetics. So we'll get the aesthetics right, and teeth around those aesthetics that function properly. And that includes vertical dimension, which we're going to talk about as well in detail. So I build the anterior. I actually leave the molars out of occlusion. And for the listeners that use any type of deprogrammer, we use one that we call the Freedom Appliance. The Freedom Appliance, I named it that because it gives the muscles the freedom to pull the condyle where the muscles want them to be. So I think muscles always win.
Yeah.
There's pathology. You either have splinting and soreness of muscles, or you have things break, right? And so I want the muscles to pull the condyle in place. And unfortunately, the posterior teeth limit how far the muscles can pull the condyle. I mean, they're in the way. And so we actually leave them out of occlusion as we restore the anterior, so the condyle can continue to be stable, or we can monitor and see those. So it used to be that I would restore the anterior 20, I'd put them in provisional. So if I change vertical, I'm not really a fan of putting them in splint and say, can you tolerate the vertical? Because you don't know when they're going to be wearing that splint 24 hours a day. They don't even when it's ugly, so they don't take it if they've got a date or a meeting or whatever. So we use the temporaries, the provisionals, as a living diagnostic splint at the vertical. So George, you could say, I'm feeling good. My wife says they look awesome. I feel good with my phonetics and again, the way my smile looks. That's a working diagnostic splint. Then we can have the lab match that and restore that vertical EP position and aesthetics that we chose. So what's interesting is I used to do the anterior 20 and then prep the molars the same day. And then I realized, that's a long visit for me, but also my patients. So I'd say, I'll come back the next day, right? And they'd call and say, my jaw still hurts, or I'm tired. Can we postpone this till next week? And I say, yeah, that's fine. And then it got to be where I never saw any failures. And I say never, I would have made them original, but nothing that was significant, right?
Yeah.
And so then I would say, well, let's do it in a few weeks, whenever you can do it. And I would try to do it within, again, a month, just to get the molars right. COVID kind of changed everything for me. I had about 15 to 20 full mouth rehabs in progress. That would either be there in the temporaries in the anterior 20, or they're in glass in the anterior 20. And that was in December of 2019, and January and February of 2020. And they didn't come back for 2 years. Some of them were, they were immunocompromised, or they just didn't want to get out and about, sort of the dental office. So they came back, and honestly, and I can say this, I had no failure, zero, no chipping. And the molars hadn't even been in occlusion. And the first question I ask is, were you able to eat? And they say, of course I was able to eat. Look at me, right? So, they say you only use your teeth only hit on parafunction and swallowing. So if you swallow right now, your teeth hit, but not for chewing. So chewing efficiency was not a problem. Function was not a problem, that they were breaking things. And so now I would say, George, come back whenever you want. I'd like to do it within the next month, but that's not a hard and fast rule for me. And it's just a good, and also I can monitor it, right? I can put the 20 surfaces, second bite, second life, mandible, and maxilla. They're all in contact when you leave. 3 weeks down the road, all of a sudden I'm hitting only on second bites. That tells me the condyle, the muscles are still moving the condyle. Thank God I did restore the molars, because that would have locked me into that existing bite. Yeah. So we're going to talk a lot. It's actually my favorite part of the courses that I give, because it opens a lot of people's eyes, and it's a little bit of a paradigm shift for a lot of people. Because a lot of dentists say, oh, you got to build the molars first and get a stable posterior. And it's like, who taught you that? Yeah, well, I don't know, because they didn't learn about it in dental school. We didn't. I mean, did you do any full mouth rehabs in dental school? No, of course we did. So I say, well, that's one way to do it. That's not the way I would recommend it. So we're gonna have fun talking about that. And I think the attendees will enjoy that portion.
Oh, absolutely. That's amazing and invaluable for anybody out there that doesn't understand or needs to understand that concept. I mean,
and to go back to your original question or statement is, if you take the bites correctly and you manage forces, you can use anything you want as a restorative. I mean, we used PFM for a long time. PFM, so ceramic is the weakest ceramic we have. And, we see failures with that. I say that they used to be a PFM and now they're just an M, right? I mean, we see that because forces were not managed and, the crown didn't break per se, so metal didn't break, but the ceramic did. If we manage forces, we can have success.
When you're doing these bigger cases, are you doing full coverage only, or are you incorporating some onlays and things of that nature into these cases?
Yeah, so I'm as conservative as I can be. That's why I said if you came in and had an existing MOD amalgam on a second molar, and I could get away with an onlay, absolutely be an onlay. And then I would switch to lithium disilicate. I don't do onlays and zirconia. So I try to be as conservative as I can. If I'm opening the bite and it's just wear, I mean, the mandibulars would all be veneers because I'm just adding, usually protracting and adding in length. And my maxillary, the linguals in my maxillary teeth will go down only as far as they need to be in contact, right? So the whole cingulum is in place. On premolars, it just covers the occlusal surface and facial. It's kind of like this little L prep or L-shaped restoration. Trying to save as much true structure as I can.
Yeah, absolutely. So I don't want to run out of time here, but there's two things I want to ask you about. So when you're doing these bigger cases, what are you using for provisionals? What's your material for that?
I use Luxitum.
Okay.
I have not entered that whole digital side of it with printing. I have a printer, but we don't use it. And the way I am going to incorporate it, because I don't use Exocad, I don't use 3Shape to design, and I don't think I can design as good as my Schmidt. So the way that we are going to incorporate it is we're going to still have a wax up done. We're going to scan that, and then that will go and be printed off the skin. But so we use Luxitem. It's a product I've been using since the mid 90s. The nice thing about it is it looks good and it's easy to use. If we're familiar with the material. If I decided to take a scan and print, if we started at the same time, I would be done with my Luxitem provisionals off of wax up while you're still washing the printed material, right? Now, some people are really, really good at it. They're doing some beautiful stuff. I think that's a really good application for printing, but I don't. I use Luxitem based off of wax up.
Yeah, I'm with you 100% on that. And then the last thing I want to ask you real quick is so when you're using zirconia, because I know you're going to talk about, luting and bonding in your course too. That's another great topic, and you're going to get into that with many, many other great things. But so when your zirconias, how are you handling that?
Well, it depends on how much retention. When people say, what's the best thing to place this with? It's always to bond, always bonded restoration. In my opinion, and this may disagree with some of your listeners, some of the attendees, if you say you bonded, you either total etched, you select etched, used a dent and adhesion, and you used a resin cement. I do not believe self-etching resin cements are true adhesion. You can show me a bar graph and I'd say, yeah, it looks good, but it's a dead tooth. And we can bond anything to a dead tooth, not a vital tooth because it's hydrophilic.
Right.
And so self-etching resin cements are luting. So, I'm a practicing dentist like you were, and, I like things that are efficient, that are easier and quicker, right? And to be able to just inject something into a crown, stick it down, light cure it, or wait 4 minutes and clean up the excess, let your patient go. That sounds good. But if it's going to compromise long-term prognosis, that's a problem. So when dentists ask me, what do I cement things with? The first thing I always ask is how retentive is the prep? And they say, well, I actually had the patient in 3 times in 2 weeks to re-cement a temporary. That's when I put this up and say, you have to bond it. They say, but it's a second molar. Well, figure it out. Have 2 assistants, hold back the tongue, use a rubber dam, use an isolite, whatever you do, but you're going to have to bond a non-retentive prep. If the statement was, no, it's really retentive, in fact, I had to cut off the temporary on cementation day, I would then ask what the material is. And if they say zirconia, you can pretty much use whatever you want. And my go-to is, I like a bioactive cement, and I'll talk about these in Vegas in June. There's a product, I hate to push products, but Theracem from Bisco is a bioactive, releases fluoride, phosphate, and calcium. And it's the easiest cement you will ever clean up in your entire life. And it's doing some very cool things as a bioactive cement for the tooth, the things that are going to cause or reduce long-term prognosis. So that would be if it's retentive. If, and I'm going to go back to this mind map. So they said it's retentive. They say it's zirconia. I say, you know what, bonding is better, but if it's a second molar, you're going to struggle with isolation. Just hold back the tongue long enough to clean the tooth off and use a self-etching resin. And there's a lot of Unisem, GSEM, ISEM, SpeedSem. Therasem is just my go-to because of the bioactive chemicals, right? There's only really a couple of them out on the market. If you said it was retentive, but it's lithium disilicate, it's Emax or Lisi Press or Amber Press, then the next question would be, how thick is the occlusion surface? Because there was a good study from Van Thompson, and mouth motion fatigue study at NYU. And if the Emax is greater than 1.5 millimeters on the occlusal, you can use whatever you want, right? It's retentive, it's Emax, it's 1.5 millimeters or 2 millimeters. Use Therasam if you want to. You're going to have long-term success. But if it's less than 1.5 millimeters, then we have to go back to bonding, right? So even though it's retentive, we're still going to have you etch. Again, I'm a total etcher, but I'm not really a fan of self-etching with the new universal adhesives, which we're going to cover in detail. I would say at the very least etch the enamel, and then these new universal adhesives are excellent. They'll bond it down, and then use a resin cement. But the key is, you know as well as anyone, it's about isolation. You know, if you can't control saliva and blood and connect, you're going to have failure.
No doubt about it. Listen, absolutely fantastic conversation. Really enjoyed it. We're out of time.
We can do this all day.
I could talk to you all day about this, and I really enjoy doing that. Maybe we'll have you back on the program if you're amenable to that.
Absolutely, anytime.
We can continue on, but we're out of time. And just do me one favor before we get off. If someone wanted to contact you, maybe to speak or to come to one of your courses or to come to your one of your live hands-on classes, how can they get a hold of you?
Yeah, and it doesn't really matter what their reason they want to get a hold of me. It's interesting, since I was on the back of your magazine, I've gotten 4 other calls from different AGD chapters. Hey, we want you to speak for us too. But if you're interested in having me speak, whether it be a school, whether it be a study club, whether it be a state or national association, or if you just have a question, I consider myself a mentor, and I do not like when I just spend, one day with the people in Vegas and I don't see them again until they see me speak again. I consider myself a mentor. I want to be accessible. So if you have any questions about any material, something that I confused you today or that I didn't answer or you want answered, then you can reach me at david@hornbrook.com. david@hornbrook.com.
Fantastic. And again, thanks so much for coming on the program. We really appreciate that. I'd also like to thank our producer, Kristen Gover. And if you like what you heard, please like and subscribe to our channel. You can always find us on Spotify, the AGD app, SoundCloud, Apple Podcasts, and of course, YouTube under @General Dentistry. If you have any questions, concerns, comments, or suggestions, you can contact us at news@agd.org. Thanks again, and we'll see you next time.
Great. Thank you.